Well, as you know, registries versus randomized trials, if you had to choose, you obviously would go for the randomized clinical trial to change the standard of care. But the fact is only about 4 to 5% of adult patients in the United States enter clinical trials because they have very rigorous entry criteria. And then we take the results and start applying it to general population in our practice, which is not always the best thing to do. So what registries do is they don't tell doctors what to do, they just gather information from what doctors are doing and then analyze it, which can inform future clinical trial design, but also let you know how doctors pick the first line therapy, second line therapy, third line therapy, how do they sequence it, what goes into that, what kind of toxicities are they seeing in the real world with a drug that we think has X% SAE or serious adverse event rate. That may or may not be the case in the real world. And oftentimes what we find reassuring is that it is actually not that far off from the clinical trial data. So you could, for example, you could have excluded elderly patients, those with brain metastases, for use of anti-angiogenic therapies. And then you realize from the real world that you can easily do that and it's not that dangerous to do. So these were done in different time points. Between 2000 and 2006 was the accrual of register and then 3-year follow-up period. So that continued until 2009, whereas sisters started enrolling in June of 2012 and stopped enrolling in June of 2016, so a 4-year period, and it has a 4-year follow-up period, so it'll end in 2020. So interestingly, at the first registry time, the only drug we had for HER2 positive patients was trastuzumab, number one. So it by default became a drug-based registry. So we entered only patients who were receiving trastuzumab, otherwise they could not go on the registry. What was common in the both was everybody had to have metastatic breast cancer and they needed to be put on treatment 6 months, up to 6 months prior to enrollment. So that was common between both. But by the time second registry opened, not only was trastuzumab moved to adjuvant setting and patients who entered the registry had received, for the most part, adjuvant trastuzumab unless they were de novo metastatic. And the other was that we had 4 drugs already on the market, trastuzumab, pertuzumab, TDM1, and lapatinib. So it became a disease-based registry, regardless of which drug was used, even if it was not a Genentech product, because Genentech was sponsoring both registries and the data is housed with them. They even allowed patients on if they received no anti-HER2 agent, but were HER2 positive. So it was truly, the second one is a disease-based registry. When you compare the populations, it's very interesting that sisters' population is on average 4 years older. The time to relapse from treatment to relapse was 20 months in the first registry because there was no adjuvant trastuzumab, and it was 47 months in the second registry, more than twice as long. So that was very striking. Another interesting thing was the mix of de novo and recurrent patients. It was 30% de novo, 70% relapse patients in the first registry. In the second, it was almost 50-50, because as the pool of recurrences shrinks, that vacuum will be filled by de novo patients in any proportional chart, and you're divvying up the pie. So that clearly shows that we have reduced recurrences. And this is community data, not clinical trial data. Another interesting thing was the hormone receptor status of these patients at entry. And previously, in the previous registry, the mix was about 50-50 of ER positive and ER negative. In the current registry, it's 70-30, which again shows that we have actually decreased the proportion of ER negative patients by preferentially curing them with chemotherapy trastuzumab, because we know that chemotherapy doesn't work as well in ER positive patients. That we know from neoadjuvant trials. PATH CR rate of ER positive patients is always lower than those who are ER negative in a HER2 positive subset. So that again was nice corroboration of the observations from clinical trials. So in many regards, it was a very instructive exercise. Finally, we have looked at the CNS data, and the second registry showed that 9% of patients have CNS metastases at presentation. These patients ordinarily cannot enter clinical trials unless you have treated them and shown that they're stable, etc. So it wasn't surprising that they live shorter than those who don't have brain metastases. What was interesting was that despite shorter survival, their average survival was about 22 months, which is much longer than what we would expect from the literature. So that's a nice finding of this registry. When this registry ends, we could open a new registry, depends on what everybody's interested in finding out. So I don't know if it'll be a PARP inhibitor specific or we'll start a new registry of disease specific rather than treatment specific data collection. But I think that this registry will keep bearing fruit. There are many future analyses pending and many publications to bring forth. Today I could only present what is already in the public domain, so I thought it would be good to put it all together into one presentation.